Welcome to our second International Psychogeriatric Association Journal Club. Nice to see you all. My name is Rob Madden, and what I'm going to do here is I'm going to rename myself, and I'm going to put the country where I'm from. So Canada, this is where I am right now. I'd encourage the rest of you, just because we're an international group, please feel free to rename yourselves and indicate what country you're currently in, and that would be very cool. So much appreciated. Okay, so we've had 30 registrants, but I see that we're up to 16 right now, so I think we could get started. And I'd like to share my screen for a moment. Just as we get started. Okay, great. So welcome. Today's November 15th, and we're going to be talking about a paper, very interesting paper about the use of aspirin to prevent depression in older adults. So a very interesting topic. I'd like to present Dr. Emerson Marinas, and Emerson is a geriatric psychiatry subspecialty resident who's in the University of Toronto geriatric psychiatry subspecialty program, which is a 2-year program. So if you do your general psychiatry program, and then there's 2 years of geriatric psychiatry, there's some overlap. So that's the way it works here. And Dr. Marinas went to medical school at McMaster University in Hamilton, Ontario, the general psychiatry residency in University of Alberta, and is now finishing the subspecialty geriatric psychiatry training at the University of Toronto. So I'd like to thank Emerson for doing this today. And so we have had one presenter, Jeff Cummings from the States, and one from Canada. Hopefully we have 2 more journal clubs coming up. One is February 8th, which I believe is at noon, and then one in May, which is later in, I think it's in the evening, to accommodate more people. So if anybody's interested in presenting from outside of Canada or the US, let me know. We'd love to have you participate. Just some brief housekeeping items. You can use the chat to indicate that you have a question. This is really informal. It's perfectly fine to ask questions throughout. I'll keep my eye on the chat, so please feel free. If you have a question, I'll ask you to unmute your microphone and turn on your camera. So when we have our discussion, we'll probably turn on our cameras. But if you're eating, or if you don't have your camera on, that's fine. If you have any technical problems, you could do the old thing, log off and log back on. And Denise from the IPA is keeping track of who's in the waiting room, and we'll keep admitting people in. And we are being recorded. This will go on the learning portal. Just to remind everybody that this is accredited for CME by the ACCME. And finally, we have learning objectives. So by the end of the session, you'll be able to describe the role of inflammation in geriatric depression, describe for rationale for using aspirin to prevent geriatric depression, and apply critical appraisal methodology. And there's no disclosures or conflicts of interest. So here are the other 2 dates. February 8th at 11 a.m. is Central, that's 12 p.m. Eastern. Let's see here, so that would be 9 a.m. Pacific, and I keep having to do the math and I'll get a headache, but you know what I mean. You have to, we send it out so you can check your local time on the flyer. Okay, so just to keep plugging our IPA Congress. Next year, the meeting's in Portugal, but we still have our virtual meeting this year with our live and on-demand content. So I'm going to stop sharing. I'm going to hand it over to Emerson. So go ahead, Emerson, take it away. And if anybody has a question or comment, just put it in the chat and I'll keep track of it.
Thanks a lot for the introduction, Dr. Madden. So as already mentioned, I'll be covering a paper on the effect of aspirin compared to placebo on the prevention of depression in older adults, and it's a randomized clinical trial. And I'll try to keep things as a short summary because I'd be interested to see what a lot of the discussion is and kind of gearing this towards my other co-residents, and it'd be interesting to hear what others with more experience have to say. Okay, so as previously mentioned, no conflicts of interest. And these were the objectives as previously outlined. And so overall, the interesting part of this paper is that it contextualizes inflammation and depression, which is something I've been hearing more and more about throughout my general residency, but I never had a great sense of what it really meant. Overall, it seems to be that a lot of the research is showing that it's quite a complex relationship, and it's probably more complicated than something that's unidirectional or bidirectional. This paper, that was a review paper in Nature, really summed it up quite nicely with an evolutionary lens, with how both anhedonia and depression, as well as anxiety, may have been evolutionarily beneficial, and there might be a reason why those genes were conserved, but not necessarily always helpful in our current society and our current lifestyle. So previous stress would have been in hunter-gatherer days where there were predators or pathogens, so kind of non-sterile stressors, as they would call it, which would cause an inflammatory response, right? In terms of survival, it would lead to things like being quite vigilant, avoidance, leading to something like the regular inflammatory response and decreased autoimmunity overall in earlier times. And overall, the inflammatory response was usually beneficial for wound healing, fighting infection, right? However, as we become more modernized, things change and the stressors aren't necessarily the same. We're not experiencing the same mortality from infections, but now we have more inflammatory conditions and chronic conditions as well. Also, the environment is stressful, but in different ways. And does this all come together and manifest as what we see as depression? Is just another figure that shows how interconnected really the whole body is with the theories about inflammation and how that affects what we see in depression, right? It talks about how the kind of stress that we have with our brain can affect things like the bone marrow and production of different blood cell lines, such as the monocytes, right? Which can affect other downstream cell signaling, right? And so stress can be through either what we perceive or other sources, such as infections, so classical things like pathogens that cause stress, like bacterias, or what we call sterile injury, which is also other kinds of stressors, which can include things like psychological stress, just because that doesn't have the same sort of infection risk as classical pathogens do. But overall, they converge together to affect downstream signaling with TNF, IL-6, which are commonly seen inflammatory biomarkers, which then kind of circle back to affect the brain. And again, the big thing to take away from this schematic is that when we start to have inflammatory signals affecting our brain, it can change things such as production of different neurotransmitters, as well as different neurocircuitry and how they function, right? And that can affect overall what we see in terms of behavior. We start to see anhedonia, which was theorized to be more beneficial in that it promotes time to withdraw and for wound healing and overcoming an infection. Or the other side is we can also see a lot of anxiety, hypervigilance, making sure that you're not attacked by certain predators or other pathogens. Overall, this changes the balance of the neurochemistry, which may affect our mood and our anxiety and overall behavior, again, due to the convergence of what we evolved with versus today's environment, that might come out as depression. Specifically to the older population, there's a bit of an overlay of what inflammation role is in depression. So overall, studies have shown that inflammatory biomarkers increase with age, and most consistently seen peripherally is that there's an increase in plasma CRP, IL-6, and TNF alpha levels in studied patients with MDD. Overall, this shows that it's a multifactorial and multi-directional relationship between the inflammation that we see and possible etiologies, as well as what we start to see in the laboratory abnormalities or just changes, right? And that's only the surface, because there's also differences in terms of neurocircuitry and brain function. So it can be quite complicated overall, and people aren't really sure if it's as simple as a chicken or egg situation with inflammation and depression. And again, this just shows how in older adults, there's lots of different factors that can lead to medical illnesses, which can be associated with depression or also complicated by depression. And also depression can affect and also worsen a lot of medical comorbidities. And so this paper that we're going to look at also looks at aspirin specifically, which is a COX-1 and 2 irreversible inhibitor, and it's been shown to decrease the inflammatory response, including IL-6, CRP, and TNF-alpha in the periphery. And so there's also postulated to be a possibility in terms of preventing the role in vascular depression, as well as cognitive impairment in Alzheimer's. However, there doesn't seem to be a robust evidence base to definitively guide us in terms of treatment and prevention using aspirin. There's some support as well for using aspirin as an adjunct in terms of schizophrenia, because there's also the theories of how there's inflammation and changes in terms of inflammatory biomarkers in schizophrenia, as well as other psychiatric illnesses. And since this study tends to look at things from a prevention lens, it's kind of nice to know that aspirin is widely used by other disciplines. So could we join them in terms of the primary prevention lens? Because overall, the primary prevention role of aspirin is still being investigated, which leads us to the principal study of what we would look at. So the Aspirin study, which was pretty much looking at aspirin being given to a healthy adult population and how it affects all-cause mortality. And so it was originally published in the New England Journal of Medicine. And there were multiple offshoots from this principal study that looked at different types of outcomes that they were hoping to measure in terms of if aspirin was effective in prevention, including cardiovascular issues, as well as psychiatric issues, which is what we will focus on. So the Aspirin D, which is the sub-study that looked at if there was a role for aspirin in the prevention of major depressive disorder in both incident and recurrent MDD episodes. Aspirin D used the same population, study population as the parent study. It was a multi-center RCT that was double-blinded and placebo-controlled, had a large population of over 19,000. They selected for healthy adults in both the US and in Australia. They selected for older adults, age over 70 for most, but over 65 with African and Hispanic Americans. And one of the key things about this study is that it's a focus on prevention, since a lot of what we're doing in psychiatry is more treatment after something has already occurred, such as the depression is already diagnosed. And they contrasted that to how a lot of other specialties have a lot of breakthroughs in terms of prevention, and how that's actually helped with a lot of morbidity and mortality in some ways, right? And hopefully, depending on the findings, the investigators were hoping to find possible clarity in terms of a causal relationship between inflammation and depression. So the main study question was, would low dose of aspirin at 100 milligrams a day reduce the risk of depression in healthy older adults? And the thought was that if you're able to decrease the inflammatory biomarkers and inflammation overall, does that lead to a prevention in the occurrence or recurrence of depression? Well, this is a table that talks about the methods that were used in the study with the details in terms of follow-up. However, tried to simplify it to show that there was recruitment in both the US and in Australia with randomization, including age and site stratification. People were either randomized to receive aspirin daily or the enteric-coated placebo. And then annually, they measured the CESD-10 scores, as well as the SF-12. And so the CESD, which I'll show, is a questionnaire that they used as a substitute for a structured interview in order to gauge if a patient would meet criteria for depression. And the secondary endpoint of quality of life was measured with the SF-12. So in the parent study, there was the primary endpoint of death or dementia, as well as the persistent loss of a single activity of daily living function. Specifically with the Aspirin D arm, the principal outcome was seeing a score of 8 or above during one of the follow-ups with the clinical epidemiological study depression. It was a shortened scale of 10 questions, which was taken as a proxy indicative of major depressive disorder. But their secondary outcome was mainly quality of life and looking at the summary score of the mental component of the questionnaire. Exclusion criteria really focused on a lot of the comorbidities that may be confounders in terms of the patients that we'd see. So any cardiovascular event or disease, atrial fibrillation, dementia, a lot of disability, condition with risk of bleeding, especially with aspirin or anemia, something that's likely to cause death within 5 years, and the use of other antiplatelet or antithrombotic meds, already using aspirin for secondary prevention or uncontrolled hypertension. And this encapsulates a lot of the patients we see overall in clinic, at least from my experience, but this does show, this may help us help guide us in terms of the prevention lens with excluding these kinds of patients for study. And for my co-residents, this is just the questionnaire that was used in order to assess for major depressive disorder. It was a scale talking about the severity of symptoms, and it's scored with 8 being the cutoff that they use, indicative of incident or recurrent major depressive disorder. And it really looks at a lot of the different symptoms of MDD. And this is the other questionnaire that they use, the SF-12, in order to look at quality of life with focus on the mental aspects and the score that was obtained from that. So overall, in terms of results, they were able to show that in terms of randomization, they had very similar groups in both the placebo and the treatment arms of the study. And you can see that overall, the cumulative incidence of depression did not separate from placebo. There was no statistically significant finding of any improvement of using aspirin over placebo. It really showed that it was not necessarily an effective preventative measure against depression. And this is just a table that shows that there was no significant separation in terms of the change in CESD-10 scores, showing that there's no significant difference in terms of the incidence of depression between the two arms again. You can see the odds ratio is quite close to 1, and the confidence interval does cross 1. In terms of secondary outcomes, there also wasn't a change in terms of quality of life. With the aspirin or the placebo group. There's even thought that they might actually have been associated with worsening in quality of life. And usually the differential change was in the negative. There was also no differences in terms of the outcome of hospitalization for depression. We also then had an exploratory endpoint where they moved the different cutoffs to a score of 10 and 12, and they again didn't find a significant separation between placebo and aspirin in terms of preventing major depressive disorder. So overall, they found that there wasn't a great difference in terms of, a significant difference statistically between the prevention of depression, but it did have a statistically significant increased risk of bleed and death in the treatment group, which suggested that the risks of using aspirin in primary prevention of major depressive disorder outweighed the benefits. Right? And this added to the null findings found in the other Aspirin studies that were conducted regarding cardiovascular events, disability-free survival, and all-cause mortality. And so we were finding that overall, there wasn't as much robust reason to use aspirin in terms of primary prevention. But I always have to remind myself that the study looked at prevention specifically and didn't really focus on treatment of major depressive disorder with anti-inflammatory or aspirin. Overall, the study was quite large, over 19,000 patients, and they were able to have quite good follow-up over the duration of the study. And they were able to account for most of their patients as well. That being said, they had annual follow-up in order to assess how things were going, right? And overall, they're trying to see the role of ASA in the treatment of depression rather than prevention, because there's some studies that suggest that there's some efficacy in psychiatric illness treatment, either as a monotherapy or as an adjunctive therapy with different anti-inflammatory agents, including like celecoxib and minocycline. And it's a growing field of evidence where we just need a bit more support to help guide us in terms of definitive treatment. Limitations in terms of the study is generalizability. So looking at the patient demographics table, most of the patients were Caucasian, healthy, and had a higher baseline quality of life. And so really seeing that a non-Western population, would this necessarily reflect the same findings in terms of ASA and prevention? Unclear, especially if there's countries that have increased difficulties with access to psychiatry. It may be helpful to look at if ASA has a role in prevention in those populations. They also did mention that although the questionnaire they used was validated to be used instead of structured interviews, still listed as a limitation, because we know that sometimes the interviews can still tease out different details than the questionnaire, especially because it was self-rated. And the 1-year intervals for follow-up were also mentioned, given that it may miss depression that happens within the intervals or multiple instances versus the possibility of a lack thereof in the interim, whether in the treatment or placebo arm. And so they're thinking that maybe if there was a smaller window, we'd be able to get a bit more information of a possible separation. And so going through critical appraisal for my co-residents, there's a great website that kind of takes you through what to look for with different papers to see see how rigorous the methods and the results are. And so looking at it, there's a series of questions to ask. So was the assignment of patients to treatment randomized? And through the methods section, they were randomized. And that was confirmed with looking at if the groups were similar at the start of the trial, seen through that randomization and demographics table that they were similar, and there was no statistically significant difference between the groups. And aside from the allocated treatment, the groups were treated equally based on what was stated in the method section. And then were all the patients who entered the trial accounted for, and were they analyzed in the groups to which they were randomized? And so pretty much asking if we are able to account for the patients, and also if there was an intention to treat protocol, which was mentioned in the method section. And were the measures objective, or were patients and clinicians kept blind to the treatment, and they were stated to be a double-blind study with the placebo as well. In terms of looking at results, how large was the treatment effect? And it's a bit different because this study showed no difference in between placebo and ASA, so there was no treatment effect. And question of external validity, which we already discussed, will it help in terms of caring for our patients? Really quite limited, I think, in some ways in terms of population demographics, because geriatric psychiatry and psychogeriatrics usually seen with lots of complex patients, lots of medical comorbidities that affect a lot of our treatment plans. Also that based on demographic information from the groups, it may also be limited and may also differ based on the ethnicity of patients, also where they live. And also helpful in some ways because it informs us about ASA's use in prevention, although in a quite a healthy population, and it shows that it wasn't, it didn't really support the use. Also helpful for me in terms of conceptualizing the role of ASA, because a lot of the patients that I see in the various clinical settings are usually on ASA. And sometimes I do wonder if that may be preventing depression or if it has a role. And other areas of study then moving forward include possibly looking at ASA at different doses in terms of prevention as well as treatments of depression and other psychiatric illnesses, but also looking at the relationship between inflammation and health from the other lens, so from the other side of things. So looking at psychotropic medications and do those help with medical illnesses. One thing that Dr. Madden pointed out that we've heard about quite a bit is the use of fluvoxamine in the treatment of COVID-19, especially since it's known as such an inflammatory infection, and how that's been helpful in terms of preventing more severe illness in these studies that are being conducted. And so it's neat to see kind of both directions going on in terms of the role of psychiatry and inflammation throughout the rest of medicine. And these are just some selected references for the journal club. And thanks.
Okay, great. Thank you, Emerson. All right, so I'm seeing there's already some questions in the chat and we see some applause. Thank you, Dr. Bingham. So let's see here. So there's a question from Elisa Georgiou from Greece. Would you like to unmute your mic and ask the question? Go ahead.
Hello, and thank you for your presentation. I would like to ask if another anti-inflammatory drug like paracetamol or ibuprofen would help with that scenario, like the inflammation and all of that, and ask about the systematic side effects, like there would be much more side effects with ibuprofen or NSAID. So yeah, what's your opinion on that?
Thanks a lot for the question. And it's something that I'll have to do a bit more reading upon in terms of the literature with the use of some other anti-inflammatory medications, or like acetaminophen, paracetamol itself. That being said, I think there definitely can be a role, especially because some of the treatment studies looked at things not necessarily ibuprofen, but more celecoxib as treatment for depression and schizophrenia, as well as minocycline. I think that the reason why aspirin was chosen in this particular study was more because of, rather than treatment, they were looking at prevention. And since aspirin is used widely in terms of prevention, secondary prevention actually more in cardiovascular, which is why they also looked at the primary prevention lens, but they've seen that it's used more widely in a prevention lens. So hopefully more tolerable, but I think that was definitely something they considered, especially with the possible side effects and the hesitation you sometimes have with NSAIDs in older adults. But I think the studies are still ongoing with those.
Thank you.
Okay, and then I'm just going through the chat. There could be other questions or comments. Dr. Verhoef, Paul, go ahead, from Canada.
Right. Thank you so much, Rob, and thank you so much, Emerson, for this very interesting presentation and a very, very clear presentation as well. 100 milligrams a day of aspirin doesn't seem to be a very high dose. It means close to the dose for stroke prevention and neurology and prevention of myocardial infarction. So question to me would be, would it be high enough to actually have a substantial anti-inflammatory effect in the brain, particularly also taking into consideration whether or not it's actually sufficiently passing the blood-brain barrier to get into the brain? That's my question to you, basically.
But it's a really interesting question, Dr. Bierhoff. Thanks a lot for also coming. And so it's interesting because one of the papers I looked at was mentioning that ASA has a dose-dependent relationship in terms of depression, but it was actually that at higher doses, it actually worsened depressive symptoms in a study population. And so I'm actually not too sure what to make of that. whether ASA at 100 milligrams was either not as bad because it either didn't cross or because at lower doses might have a different mechanism. I'd be interested to see if they did ASA at a lower dose and if that had a different, also a different effect in terms of depressive symptoms. But overall, I'm not actually too sure.
And just one follow-up question, which I also wrote in the chat, but we know that there are different contributors causally to depression. And in the large group, could it be that still there are certain subgroups of people with depression that might benefit, but we just are not able to tease it out because it may be like a minority of people where like this type of inflammation plays a very important role. For other people, like monoamine disbalances or other issues play a larger role that are less related to inflammation.
I think that that's also a great consideration, especially given that that level of discrimination between the different types of people was taken out of the study because of the strict exclusion criteria. Because you would wonder if separate from in terms of inflammatory chronic illnesses, if separate from helping out with the disease burden, if anti-inflammatory medications themselves might also help with mood in a separate mechanism. But not actually too sure right now, but that'd be interesting to see. And just the way this study was structured, it didn't seem to be able to make that discrimination, especially with the questionnaire. You really lose that level of granularity.
And actually, a very last question, then I'll stop. But did they say anything about like co-interventions? For example, I can imagine via nutrition that people, if they eat more antioxidants or other like substances that might reduce the effect of inflammation in the brain and elsewhere, like just diet, might actually have an effect too, and that they control for that in this study.
From what I saw, they didn't mention it as something that they controlled, but also a good point, especially with diet and the microbiome itself, adding another layer of complexity to an already complex concept.
Okay, thank you. So yes, comment from Carol Cohen. Go ahead, Dr. Cohen.
Yeah, I was just reflecting on the fact that science is so interesting and that I don't know that a study like this would have even been possible now, given that the recommendations have changed with respect to people using aspirin for prevention. So as our knowledge changes and recommendations change, this study I don't think would have been one that would pass the REB given the GI complications that they allude to.
Okay, thank you. Do no harm. So Gina Eom, subspecialty resident, incoming subspecialty resident. Congratulations. Dr. Eom has decided to become a geriatric psychiatrist. Go ahead.
Oh, thank you, Dr. Madden. Oh, I was just commenting on Dr. Fairhoff's question about CNS penetration. And I'm also not sure whether or not aspirin, how good its ability is to cross the blood-brain barrier. But I do know that some of the neurologists prefer to use diclofenac in the powder form. It's called Cambia for better CNS penetration profile. So if some of the mechanisms that were proposed by Emerson earlier on in that 2016 Nature Immunology review, if that's the basis with which they started the trial, theoretically, that would be an interesting other agent to consider in the future. But I also take into account Dr. Cohen's point that, we don't want to do any more harm and that some of these NSAIDs are not benign in terms of GI side effects and otherwise. So just a comment.
Okay, any other comments or questions? Any other thoughts about the study, about the methodology, or how they drew their conclusions? Is anybody going to take an aspirin today? Anybody can take an aspirin? No? In Canada, it's 81 milligrams, baby aspirin, they call it. Well, the other thing that's of interest to me is the role of inflammation is very interesting in terms of Alzheimer's disease, bipolar disorder, and mood disorders in general. then for, since we're late life psychiatrists, geriatric psychiatrists, and within the field of, late life mental health disorders, I'm assuming we're interprofessionals. So the whole thing around cerebrovascular disease and late life mood disorders is very interesting. And also the role of cerebrovascular disease even in dementia and Alzheimer's disease. So when I think of aspirin, I think of antiplatelet effect. It's the first thing I think of. I didn't think of inflammation. So those are that's just another angle. But again, it could be that on the whole, there could be a subgroup, as Dr. Verhoff says. If we look at people with geriatric depression, they're probably not all the same, right? There are people who've had depression recurrently throughout their lives since they were younger adults, and now they're older and they have a mood disorder once again. And there are people who get it for the first time with no personal psychiatric history and maybe not too many risk factors and are getting it. And the whole concept of vascular depression is very interesting and how that could be treated. And the role of cerebrovascular disease, not only in depression, but in dementia, and the fact that people with depression are possibly higher risk of developing dementia later on is of interest. So I don't think we fully understand it. Yeah, so Dr. Bingham.
Thank you. Yeah, thanks for the presentation. I thought of something else when you mentioned that, people certainly could be aging with depression versus late onset depression. And just remind me with this study, what was the follow-up period? Like when would they have started the intervention?
From my sense is they did a baseline score and then they just started right away and then would follow up once a year, pretty much. And then because they couldn't separate out, as you mentioned, kind of incident depression in late life versus recurrent, they just kind of put them together in their study analysis.
Yeah, because I'm just thinking like a lot of these things, including dementia, like we think that probably onset of the risk factors is maybe like in midlife or even before that. So by the time they were to start primary prevention, it was probably too late, to really modify those risks. So I think it's not, I think it's not really surprising that it was a null study, to be honest. And I see Dr. Cohen said that it was a sub-study. It was a large study with a sub-study focused on depression, which, has its own kind of methodological issues too. So yeah, but thank you. That was helpful to go over.
It's also interesting because thanks for mentioning that, because it cued to me that it's really a patient population that we might not usually see because they're so healthy. And usually we'll see someone with a lot of comorbidities and the diagnosis of depression. So maybe more helpful in colleagues in family medicine rather than us. But I'd be interested to see if there's a role in terms of secondary prevention after they've had a medical event already in preventing depression.
Mm-hmm. No, that's a good point.
I just wondered about the negotiations to include an arm that dealt specifically with depression, because it's not usually the case that the psychiatrists are in on the ground for a large prevention study like this. So I thought that was interesting that, they actually turned their mind to depression and the psychiatric condition in a large study like this. So somebody did a good job getting us in on the goods.
Okay, so Gina Eom, a good question. Why did they have a younger age inclusion for non-white trial participants? It's a good pickup, Gina. I didn't even see that.
Thanks for bringing that up, Gina. I'm actually not sure. I was wondering if there was a difference in terms of risk factors, but I would probably have to go through the parent studies methods. It's in one of the supplementary, it's a large document, just to see why, because that would have been something that they applied to all the sub-studies and the parent study itself.
Okay, any other Thoughts, comments, questions, criticisms, jokes?
I wondered if you wanted to comment, Emerson, on the fact that it was done in 2 different countries, yet the majority of the patients recruited were in one country. And obviously, one could think that the Black and Hispanic patients were recruited in the smaller subsets. So what some of the issues were related to that?
I also thought that that's interesting. You bring that up because their method of recruitment was also different between the 2 countries. And so I wonder if that also affected, like, as much as it's not reflected in terms of exclusion or inclusion criteria, the findings that they were able to generate, because the possibility is that they also have 2 different populations within their study population. So yeah, it'd be interesting to look through the methods to see like the rationale behind those differences and why those 2 specific countries.
Any other thoughts or comments?
Just maybe like for the Alzheimer literature, Patrick McGeer, I think was his name, like in British Columbia, found this relationship between NSAID use and reduced risk of developing Alzheimer's disease at some point, and then zoomed in on ibuprofen. That's why I wrote my message also, that is one of those NSAIDs that penetrates the blood-brain barrier better, goes to the brain. I'm not aware that his group found any relationship with depression, but maybe they didn't look at that. But Emerson, did you look in the paper or elsewhere that they mention the role of other NSAIDs, and also like Gina says, there's like others that may like diclofenac, Voltaren, that might get better into the brain. Whether there was any possible preventative relationship that in any studies?
Unfortunately, I didn't get to take a look too much into that side of the literature. And now that diclofenac is mentioned, I'm surprised that I didn't. That's actually not something that I saw very often. Usually what was mentioned was more celecoxib, and I'm not actually sure why that choice was made. Maybe it's like the selectivity or the availability, but I'm not too familiar. And like in terms of, like, I think it's still growing as a field as well. When I was looking into ASA in terms of Alzheimer's, couldn't really give a definitive recommendation either, and it seems a bit mixed. I'd be interested, especially because I don't know what to make of it, but they did mention in one animal study that using ASA or anti-inflammatories helped with like reduced immobility in a swim test with rats, but increased like preference for high, like sugary foods. And so I'm just wondering, like they took it as a change in terms of the salience networks and attention, but it just makes me think of, does that also affect vascular risk factors adversely, possibly?
Okay, any other comments? Any other medications that could cross the blood-brain? It's diclofenac. Voltaren? No, yes, it's diclofenac, right? There it is, that one?
Yeah, cool.
So I'm almost 50 years old, so everything hurts me. And I'm using Voltaren on a regular basis. I don't think it's crossing my blood-brain barrier. Okay, well, look, thank you all for joining us. Emerson, thanks for doing a great job. And this is really an interesting topic and a great paper. So the IPA will send you an evaluation form, each of you, to fill out. So please do, we really appreciate the feedback. And if you're enjoying this so far, we have another one February 8th, and then another one in May. So you'll see those announcements come out. And feel free to hang around a bit longer. We have the room until 1 or shortly after then. So if people want to hang around and talk and chat and get to know each other, please feel free. I'm going to hang around. But if not, you can certainly take off. And thank you very much for joining us. Thank you, Emerson.
Thank you.
And Woodrick, who is AMDISSF.